So the topic for this afternoon's presentation, which is a continuation of our session this morning, is on neurobehavioral approaches in Angelman syndrome, part 2. So we've organized our talk around the health watch tables for Angelman syndrome that were developed a couple of years ago, and the online behavior modules that have been available for a few years now as well. We want you to learn how these resources can be used to help individuals with Angelman syndrome receive appropriate care and support to maximize their physical, behavioral, and mental health. And we're including information from our clinic in Ottawa that we started last year, and including some case examples. So a little bit about us. I'm a psychologist. I work at the Centre for Addiction and Mental Health in Toronto. Dr. Sell is a neurologist at Children's Hospital of Eastern Ontario. We happened to meet each other in a conference in Chicago a couple of years ago and talking about our mutual interest in Angelman syndrome, and we thought, wouldn't it be a great idea if we could work together? So we figured it out. We figured out a way for us to get together a few times a year in Ottawa to see families and kids and to try to help them. And we've been helped greatly by the financial support of the Canadian Angelman Syndrome Society, who makes my flights there possible. The aims of our clinic are to improve physical and emotional health for people with Angelman syndrome and reduce occurrence of challenging behavior. We want to enable individuals with AS to reach their full potential and maximize their quality of life. If you came earlier today, you heard a little bit about the Angelman Syndrome Health Watch table. And if you didn't, it's information that's available freely on a website. If you type in the words Surrey Place Centre and Angelman Syndrome Health Watch table, you can pull up the PDF and you can just print it and download it. It's a very helpful set of guidelines that allows you to have a better understanding of what are the health-related needs of people with Angelman syndrome and how to provide anticipatory guidance and surveillance around these healthcare needs. So Dr. Sell talked a lot about the health-related issues from the Health Watch table. Now I'm going to talk about optimizing behavioral and mental health. And I'll be referring to the behavior modules that have been developed in the Health Watch table too. Okay. So the Health Watch table covers a number of areas, and many of these were covered by Dr. Sell this morning. I'm going to talk about mental health and behavioral issues, safety, and pain and discomfort in greater detail. So the Health Watch table starts by describing mental health and behavioral issues in the population. And it describes Angelman syndrome in terms that are familiar to many people. They refer to frequent laughter, apparently happy demeanor, easy excitability, hyperactivity, sleep disturbance, and aggressive behaviors such as grabbing and pulling, but not self-injury in Angelman syndrome. Around these behaviors, they provide a number of guidelines. So for hyperactivity, they mention arranging consultation with an occupational therapist for sensory issues. Do many of your sons or daughters see occupational therapists? Is that pretty common? Some, yeah. Do they deal with sensory issues? So like a sensory assessment, they try to see what sort of sensations they're seeking out, what they're avoiding, and that way you can sort of build a sensory diet around their likes and needs, which might have a calming effect upon them. They recommend seeing behavior therapists and then a psychiatrist to consider medication management for hyperactivity. But I think Logan Wink's going to talk about medication management, and sometimes there's an atypical response to stimulant medication. From a behavioral standpoint, I think we can work on shaping individuals to learn how to pay attention for longer periods of time and know how to rearrange the physical and teaching environment so we can promote better attention and better concentration. So it's not just medication, it's working with the environment and working with the person to teach them skills to improve their focus of concentration. Sleep disturbance. How many parents here are dealing with sleep disturbance? So it's pretty common in Angelman syndrome. Very high rates of sleep problems, which include an apparently decreased need for sleep, apparently, not always, abnormal sleep-wake cycles, difficulties falling asleep or remaining asleep, reduced total sleep time, disruptive bedtime behaviors are all very common. Problems can have a significant impact on family functioning, obviously. The finding is that sleep is most affected in infancy and middle childhood and tends to improve in adolescence and adulthood. Although it can still be a problem, it tends to get better over time. Some of the recommendations from the Health Watch table and some of the things we've added of our own are implementing a consistent nighttime routine. So many of you will find if you do things in a very systematic, consistent way, your child's learning to associate being drowsy with going to bed. There's a wind down routine in the evening where you're not giving them a lot of stimulating activities. So your goal is to wind things down, help the child to become drowsy, and help induce those cues that would promote sleep when they go to their bedroom. People modify the sleep environment too, so there's various things we can talk about what they like to do. A lot of parents consider a trial of melatonin. I'm just wondering how common that is here. Quite a few people are trying melatonin. Possible referral to a sleep clinic or specialist if needed. Sometimes behavior therapists get involved to look at the parent-child interactions, because when parents don't get any sleep, they'll do anything in their power to get their child to sleep. And sometimes that can evolve into routines that are not helpful in the long run. Maybe in the short term your child's sleeping, but you're doing things that are not healthy for your sleep or the family's sleep. Sometimes sleeping in bed with your child, or coming in and getting them up in the middle of the night if they're not sleeping, taking them out to the living room to watch TV or listen to music. That might work in the short term, but in the long term you're setting up new patterns of behavior that are difficult to break. Sleep apnea can be an issue in Angelman syndrome, but can be difficult to diagnose because of the need to go to a sleep clinic and wear the equipment. And then if they were to have sleep apnea, it's difficult to wear the CPAP machine. Some parents have reported, though, if their sons or daughters' tonsils and adenoids are removed, or if they lose weight, it can help with some of those symptoms. I don't know if you can see it very well, but this is a study that talked about sleep disturbance in 3 sisters with Angelman syndrome. And they used a variety of techniques to look at their sleep quality, and they were able to detect that one of the sisters had sleep apnea that they were contemplating providing treatment for. So they wanted to point out that sleep apnea should be considered in cases where sleep deficits are a major issue. In terms of data from our own clinic, we've had 21 families come through our clinic. The majority are deletion positive, but we all have 4 different genetic subtypes represented. The age range is from 2.5 to 20 years of age. So we each ask very systematic questions of all our families, and one of the questions is, how many hours of sleep is your child getting at night? We're getting a response of about 9 hours at night. Now this might include just being in bed. We don't know if they're sleeping, but they're in bed for up to 9 hours at night. Many parents report that the child has difficulties falling asleep, but more problems are found when the child needs to stay asleep. So they're initially falling asleep, and melatonin might help with that, but then they wake up and they stay awake, and they have difficulties going back to sleep. So those seems to be fairly common issues with the population. In terms of special bedtime arrangements, a lot of parents make bed enclosures. They'll put gates around beds. They'll have a tent over the bed. They'll rearrange the furniture to keep the child in their bed area. Sometimes they'll take all the furniture out of the room, so if the child does get out of bed, they're not going to hurt themselves. Some have movement monitors in the room, white noise machines, and music playing, and so on. So of the people here, do you alter your child's bedding? Do you have different arrangements for their bed at night, like gates or a bed tent or things like that? Is that fairly common? Yeah? A few have? And you find them to be helpful? Keeps them in bed. Yeah. Uh-oh. My screen did something funny again. You can see it, but I can't. Sorry. We just have to make a minor adjustment here. I'm getting this showing up again. I wonder if I have to go to...
No.
Go over to PowerPoint, or is it on sleep now? Just minimize it.
No, it's okay.
Oh, yep. We're good. Okay. So some parents want to make sure their child's safe, so they put a video camera in the bedroom as well. In terms of sleep medications, they didn't report using a lot of them, but a couple of parents reported using gabapentin and trazodone, and they felt they were helpful. And in terms of other issues they reported to us, a parent mentioned about the tonsils and the adenoids being removed and felt that their child slept better after that occurred. Pain and discomfort wasn't in the original Health Watch table, but we think it's a very important issue to be considering. And it can present as distress, sleep disturbance, or behavioral changes, such as an increase in aggression or irritability. Facial expression and vocalizations can change as well. So we think children's physical health, mental health, behavioral health are all affected by things like pain and discomfort. So we think it's very important to be able to identify it when it is happening and to try to figure out what is underlying it. So we're recommending that if you suspect your son or daughter is in pain or discomfort, try to investigate and treat possible physical causes for that, such as reflux, headaches, toothaches, sore foot, uncomfortable clothing, and so on. Also, look for and address environmental factors that might cause distress or discomfort to your son or daughter. So have you ever noticed when you go into a very crowded room or it's a noisy room, they look like they're in distress or discomfort, or if it's too hot or too cold. It's not just physical pain, it could be emotional pain or pain that's caused by other factors in the environment that we should be on the lookout for. Is that a common experience? Are you concerned that your children might be experiencing pain and discomfort? Yeah? What are the sorts of things that are underlying some of that? Headaches, toothaches, earaches, constipation. I think that's a big one, yeah. Sore feet? When they wear their AFOs, does that bother them? So anything that can bother us can bother children with Angelman syndrome, but they can't tell us it's bothering them. So we have to deduce it from their behavior. What I provided here is something called the Non-Communicating Children's Pain Checklist. That was developed by a researcher named Len Bro in Nova Scotia. And I think it was developed for research purposes, but they wanted to look at some of the factors that are important for identifying when children who can't talk are in pain or feeling pain. And it's different subscales that they have people provide ratings on. But I think it's useful for us to talk about those different subscales and how they might apply to kids with Angelman syndrome. So one of the scales is vocalizations. So they mention moaning or whining or whimpering or crying or screaming as a sign of potential pain or discomfort. Changes in eating or sleeping. You could be eating less, you could be eating more. You could be increasing your sleep or decreasing your sleep. So eating and sleep can be thrown off. Socially speaking, you could have children who become less social. They're cranky, they're irritable, they don't want interaction, or they seek comfort and they want to contact you. They don't want to let go of you and they're clinging to you because something's bothering them. Look at their facial expressions. Do they have a furrowed brow? Are they not smiling? Are their lips tight or puckered? Are they clenching or grinding their teeth? Are they chewing? Now, it's kind of difficult because with the normal facial expressions of kids with Angelman, sometimes you'll see someone who's smiling. You won't see a change in that, even though if they're in pain. You might see kids chewing, even though they might not be in pain. So it's kind of hard to pinpoint some of those things, but those could be signs that the person is experiencing distress or pain. Activity levels. Not wanting to move around in a child who likes to move around a lot, becoming less active, or showing that they're agitated or fidgety. Those could be signs to be looking for. And body and limbs, so stiffness or gesturing to the point of the body that hurts. Yes?
Do you, and I'd be interested in everyone's experience, our Angel, he's 11, and he does not seem to have the same sensitivity to discomfort that we have.
Mm-hmm.
He can be outside when we're freezing, and you wouldn't know it from his behavior. Or it can be hot, or drawing blood, doesn't bother him at all. He's happy to watch it and stick the needle, it doesn't matter. And so things like that. Have you all observed that in your angels, or have you got?
Is that a common phenomenon? What would you say?
Yeah.
Yeah. So the danger is you can hurt yourself and not know it. You're going to say something, Martia? Ah. Yeah. Yeah.
Like you'll see sweat drip off her hair, we'll see it on her back. It looks much more typical than when she was on Depakote. We always attributed it to Angelman syndrome. But now that she's off Depakote, she still has struggles to cool herself. It looks like she's more sensitive to heat than the rest of us in the family. But
So it's incumbent upon the adult or the caregiver to watch for these things when you're going out under the sun. You do the sunscreen, I guess, and the hats, you bring along the water, because the individual is not going to complain, but it could be very stressing to their body, I guess, to be under those conditions. And even though they seem to be enjoying it or not affected by it, that doesn't mean it's not affecting them internally, perhaps. So maybe one of those things to look out for. Now, how about cold temperatures? Issues with cold? No problem?
she struggles like her feet will become freezing cold very easily. So it seems like her body temperature regulation overall is diminished compared to a typical.
Does that bother her when her hands and feet are cold like that? Because it doesn't seem to bother her. We go, oh man, it's freezing.
So I don't know if it bothers her, but we have noticed if we pay attention, let's say in the hotel room, that she's cold and she gets under more covers, then she'll go to sleep. So the cold may keep her awake. And
Okay.
she can tell us that's why she's not sleeping. But then
That's interesting.
we notice it and we take care of it. A lot of times we'll see her go to sleep then.
So part of that sleep environment at night, maybe figuring out that optimal temperature, not too hot, not too cold,
Yeah,
just,
that inability to like cover themselves
Yeah.
when they're cold
or take off the covers when they're hot. Yeah, interesting. Yeah.
My son could walk outside and naked in the snow without the sleep up.
Wow. And the facial expression doesn't change, the vocalizations don't change, there's no sign that anything at all is bothering them. Just happy, yeah. So I guess it means caregivers and parents need to be just on the lookout for these things to happen and intervene before it gets to be dangerous. Let's see. So from our Ottawa clinic, we ask questions about safety and pain. So we ask, has your child ever swallowed a hazardous item? And almost 20% of the sample said yes, they had. Choking, I think there's 1 or 2 cases they ended up going to the ED to get something removed from their throat. Generally speaking, parents are very good at keeping small items away from kids and making sure they don't choke, but it can happen. Burning, I think a child touched a hot stove or rubbed their leg up against a radiator. Again, it didn't seem to faze them too much, but the parent saw the aftermath and was quite concerned and got medical attention for them. Trips and falls, you would expect it, yes, but parents are quite careful, try to be nearby in case you can sort of intervene to prevent them from falling and hurting themselves too badly. Little concept of danger, that's present in a lot of the kids and families we're talking to, which is a big concern, isn't it? You can walk out in front of a car. You could just be at the top of the stairs and just topple down the stairs. You could be in the kitchen and just grab for that boiling pot of water on the stove. Are you concerned about the same thing too, as parents? Everyone is. What sort of things are you doing to safety-proof your homes? Are there special tricks you have or things that you do routinely that take care of some of these problems?
We use electronic locks that you can buy. They're about $90-some each, but we put it on all of the doors so that we use a keypad
Okay.
to unlock the door, and then the handle will work. And he, of course, he can't. And then the outside of the property is surrounded by fence
Yeah.
that thus far he can't climb. Although we're concerned.
Yeah, you're keeping an eye on things. So he can't get outside without using the keypad. He can't manipulate that. Okay. But inside the house, he can move around freely?
He can move it well. He can't go into his brother's room or his sister's room.
Okay. Because they don't want him to.
Or into our bedroom.
Okay. But apart from that, he can move around.
Yes.
What about into the kitchen? Are you allowing him free access to food?
We have those little, they're safety things that you have to push on 2 parts of the plastic before you can get the plastic loop to pull through. And we put that over the cabinet doors so that he can't
Yeah.
in there, and he'll leave things alone. But other things, yeah, we secure it that way. And then we also use those magnetic latches, where, you know, you have to take a magnet and run it over just the right spot, and then it'll pull the latch open so you can swing his cabinet. So we use that on his drawers and his arm lock in his bedroom. And then the way, we used to do the safety bed, now we do the safety room.
Okay.
So we basically reverse the locks on his bedroom door and we lock it from the outside. And then we have 2 video cameras that allow us to talk to him through there
Yeah.
and watch him
Yeah.
and listen to him.
Okay, so you can make sure he's safe at all times, but he can't get out of the bedroom.
Right.
Okay. Any other ideas? These are all great ideas.
One for water, because they took the water in the washroom, valving out the hot water,
Yeah.
just so that they can only access the cold water too.
So you adjust it so we can't turn it to a scalding temperature, like you,
Valve it out altogether, the hot water.
oh, I see, okay. Other pearls of wisdom, tidbits? Guess you all find ways to make your home as safe as possible. So yeah, parents were concerned about that, and in terms of recognizing their son's or daughter's pain, they cried differently, vocalizations are different, screaming, whining, moaning. Some could point to where it hurt. They could tell by their facial expression. Some would lose their appetite, wouldn't drink. Some used their AAC device to say, my head hurts, or I've got a stomach ache, which is great. The better they can tell you what's going on, the more you can respond to their needs and get them some help. But that's one of the major concerns of parents, not knowing if something's bothering their son or daughter and getting help for them. So mental health and behavioral issues are also mentioned in the Health Watch table. Part of it talks about language development as being variably, though markedly impaired. So the majority do not develop speech. Receptive language skills are always more advanced than expressive language skills and continue to improve even in adulthood. So the recommendations from the Health Watch table were early and ongoing intervention by speech-language therapist is essential and should focus on nonverbal forms of communication. So using augmentative and alternative systems and aids such as POD, picture cards, communication boards, speech-generating devices, and so on should be encouraged. Would all your sons and daughters have some sort of system that they're using? Yeah. What about if they're an adult? Do they still use the system, or were they introduced to a system as an adult? Trying?
Pretty well. I'm fine.
Okay, you're fine, okay. I guess the point is that adults aren't left out of this, that even if you're an adult, you can still benefit from a communication device, and you shouldn't be neglected. We asked parents about behavioral and mental health issues when they came to our clinic, and we found that aggressive behavior in the form of hair pulling, grabbing hats or glasses, sometimes biting, pinching, or slapping were fairly common. Self-injury was also found in proportion of the sample, which was not major self-injury. It was lightly biting their hand or arm or scratching their skin. Disruptive behavior was a bit of an issue. Short attention span, yes. Excessive need for attention and non-compliance or not wanting to do what you ask them to do happens. We tried to find out the possible functions of the behavior, because behavior serves a purpose and it occurs for a reason. Parents thought that part of the reason could be that the child wants people to pay attention to them. They want to get something or avoid something, or they like to get sensory feedback through their behavior. So we wanted to get a sense of what were the different reasons why children behaved the way they did. About 24% of families thought that their child might have anxiety. They weren't quite sure, but they questioned it. They did mention a few fears and phobias that happened in specific circumstances. I think one boy was afraid of clowns, and another was afraid of trains. One family questioned whether their son is depressed. They didn't know, but they thought maybe it's possible. And I think a couple of families said their child had received a diagnosis of autism.
Can I ask a quick question?
Yeah.
Do the neurologists believe that it's like a comorbid situation of autism and Angelman syndrome, or I don't know, not being insulting, lack of knowledge and giving an autism diagnosis in lieu of having expertise with Angelman syndrome manifesting autism-like behaviors?
Yeah, I think both go. So there are circumstances, and this is well described, where children would have Angelman syndrome and be misdiagnosed as having autism. But now, because there's more awareness of autism and there's more genetic testing available, I think that becomes less and less frequent. And what can happen is that you may fulfill criteria for autism despite having Angelman syndrome. And the same thing has been described with other genetic syndromes. So there is autism spectrum disorder as a subpopulation, let's say, or a subgroup within or among children that have Down syndrome. So yeah, it is possible. And the last thing I'll say about autism is that it's a diagnosis that different from Angelman, where you have the very specific genetic marker that is kind of like a black and white, right? Either you have it or with autism, you need to meet criteria that it depends on an evaluation, and that evaluation sometimes it's a little bit dependent on who is evaluating, right? So.
On the Angelman user groups, and then my wife is talking, and I hear her talk with a couple of friends, and they've been using, in terms of talking about behavior, the word dyspraxia a lot, and they see it. I'm not sure I understand the way they're using it, or I don't understand dyspraxia. They're sort of like saying the body's doing one thing, even if the mind thinks it should be doing something else. That's a poor.
Yeah, so I think it comes down, it's kind of like semantics, but if we, in order to simplify the concept, it is praxis is this kind of planning to execute something. So dyspraxia is really a very broad term that applies to anything that you're supposed to do, and the reason that you're not doing it is not because you are weak or you don't have the part or the limb that you should do in order to do that. So for example, you can have speech apraxia, and it is not because there's something wrong with the way that you can use your vocal cords so you can scream loud. It's not because you have trouble with the way you use your tongue and your lips, because you can eat well, you can swallow well, but there's something that is within the complicated networks in the brain that is not allowing from one source to communicate to the other source so that the planning is completed. So applies to pretty much anything that requires praxis or planning and execution.
So is that a common symptom? Is that a common thing in Angelman?
Yeah, I think you could say so. You could say so. It's just that it may not be often phrased like that very commonly.
People talk about motor planning difficulties. You see it when you give children tasks to perform, like putting pegs in a pegboard, and they have to initiate some sort of motor response, and it's difficult for them. You can sort of see it. They're thinking about it. They're wanting their hand to move, but it's not moving the way it needs to, and it's that difficulty initiating that motor movement and then guiding the hand to where it needs to be, which has a functional impact in your life, because if you go through life with having all those difficulties, it's very hard to execute a lot of motor responses.
Does that lead to anxiety?
It could lead to frustration, for sure. I mean, if you think in your mind, look, I just want to zip up my top, and it's just so hard to get everything working the right way, it could be very frustrating for someone. I imagine it's terribly frustrating. Do we have any other?
I just think therapists use it interchangeably too, like dyspraxia or apraxia, ataxia. So if you're talking to a physical therapist, they might say, well, your child's ataxic. That's right. They're not walking up and down stairs smoothly because the motor planning aspect of it being a gross motor movement, they aren't able to coordinate all of that. And from a speech and language standpoint, you might say like, oh, well, they're not uttering words smoothly like you and I would because it's a motor planning act with the mouth, of the vocal cords, of all of the movements to coordinate at the right time and fire and everything to be smooth. And so therapists use those words interchangeably, and it kind of affects, if you talk to occupational therapists, they could say you're ataxic or dyspraxic with fine motor movements too, you know, like coloring, writing, pens, fine motor, and why they don't sign well, because they can't coordinate sign language with the fingers like a more typical child would, or some people with other disabilities.
Just getting back to that question about autism and Angelman syndrome, I'm aware in a couple of cases of a doctor who's made the diagnosis of autism pretty much for the reason of getting help for the child. So the parents have wanted ABA therapy for their child, and they've been refused unless their child has a diagnosis of autism. So it's been mainly to help that child access therapy that they wouldn't ordinarily have received. And I've done a couple of studies showing that ABA can work with kids with Angelman syndrome, can actually boost their skill development and boost some aspects of their cognitive development. So there's promising evidence that if you do it and do it systematically, it can be very beneficial. But people have the mistaken belief that you have to have autism to benefit from ABA, and the fact is anyone can benefit from it. So a couple of questions back there. Yeah.
How about ABA for young adults?
I don't see why it can't be done. I mean, we learn all our lives. It's maybe more difficult, but you know, the principles of setting a goal, breaking it down into small steps, helping people to accomplish what they need to do, providing reinforcement, doing it consistently. You can do those throughout the lifespan. You can teach an adult how to sit on a toilet and how to feed themselves and how to turn the pages of a book and how to do all sorts of things. You just have to set about doing it and do it consistently, and it's certainly possible. I've done it.
What about the individual that has a short attention span?
Yep. Well, you got to work with what you have initially. If you got a short attention span, you've got to work with that very short attention span, and you gradually try to lengthen the period of time they have to pay attention before they get their reinforcer. So if I can only look at this computer for 2 seconds and then I get some sort of reward for that, maybe after a few trials, I'm going to have to look at it for 3 seconds and 4 seconds and 5 seconds. So you can shape and build up attending behavior through shaping and reinforcement procedures. You also find things that draw more attention too. Some kids can sit and watch a movie for an hour, but other things they'll give it like 30 seconds. Because sometimes it's you pay attention to what you like, you avoid what you don't like. So I think it's possible to shape attention and to gradually lengthen it. It might not be like everyone else's attention, but you can definitely help it to get better, I think.
I'd like to comment on that. ABA techniques for adults, we can follow the trend. People my age, and it was successful. So it's awesome.
I think it's just thinking it's possible and saying, yes, it's possible. Let's start to organize things. Let's set it as a goal. Let's take our techniques and work it out so that we work as a team, and let's go for it.
What is ABA?
ABA stands for Applied Behavior Analysis. It's a set of teaching techniques that are used to change behavior. It's most often associated with autism, but it was really, these techniques have been around for hundreds of years probably. It involves sometimes shaping people's behavior. So if you want them to do something, you give them a little bit of help, you reward their efforts. Use different teaching techniques to prompt them, to shape them, to reward them. You're gradually teaching things in a way that's systematic and consistent. You can measure what you're doing so you can see progress and benefit, and you set goals that you're working towards consistently. So you break something down into a series of very small steps. He's going to feed himself. Okay, the first step is he learns to pick up a spoon. Next step, he learns to put it into the food. Then he scoops the food. Then he brings it to his mouth. So you can teach them every step of the way so that you chain them together so that they become one long response over time. I worked with a girl with Angelman syndrome, just taught her how to put a flashlight together. She learned to unscrew it, put the battery in, and screw it back up again and turn it on. You can just do that by shaping. And successive approximations, it's called. So the techniques are tried and true. They've been established in thousands and thousands of studies. They can be used to teach self-help skills, communication skills, gross motor, fine motor. Anything you want to teach, you can use ABA to varying degrees of success. So it'd be great if the government made it available to people, because you would be amazed by what your sons and daughters could learn, I think. But it costs money. Therapists have to be trained. It takes lots of time. Anyways, aggressive behavior, which is mentioned in the Health Watch tables and the parents in the clinic, is behavior that can result in harm to oneself, others, or the environment. Common forms of aggressive behavior in Angelman are hair pulling, grabbing, punching, kicking, slapping, and rough hugs. Do you ever get bear hugs? Yeah. I mean, it's affection, but sometimes it crosses the line. Quite often it's excitement, affection, wanting to contact people, grab them. But then it could take on a life of its own where it's, let's just pull some hair here and get a reaction, or I'm a little ticked off today, so I'm going to pull your hair, or I know you don't want to be squeezed to death, so I'm not going to let go. The problem with this is it's sometimes okay in a young child to do these things, but when you're 16 or 17 doing them, it's not okay. And the kids at school get scared. And we don't want that to happen, because we want Angelman students to be liked by everyone, and to learn how to greet people properly is an important part of growing up. You don't have to grab someone, you can give them a high five or a knuckle bump. And when kids know that, they are actually less afraid to come by and they want to spend more time with your son or daughter. We think, though, aggression in the absence of verbal and motor skills is a way of communicating. It's a way of telling the world, I want you to pay more attention to me, or I want to stay connected to you. I want something. I don't like what you're wanting me to do, or I want to do something else, or I'm not feeling well, or I'm unhappy. If you can't talk, how else do you let people know what you're thinking? You act it out, you do things. So just getting back to the ABA piece, so interventions based on applied behavior analysis are being used to teach adaptive and communication skills to improve people's functioning and address behaviors that are challenging. Just a little caveat, if behavior changes do occur, try to find out what's underlying them, because there might be a medical or emotional issue, but consider talking to trained therapists and seeing what they can offer your son and daughter too. And ask about your school. Do they have ABA therapists at school? The online behavior modules can be quite helpful to parents. If you're dealing with challenging behavior, it's a place you can go to. You can just go to the website and sign on very quickly and set up an account. And you can work through a number of modules that talk about important aspects of dealing with challenging behavior. Because challenging behavior has many different facets to it. You need to understand all of them. Sorry, it's gone crazy again. Let's see here. Nope. Which slide am I on here? On this one? Mm-hmm. Okay. Yes. So it's got a variety of modules that you can just go through at your leisure. You can log on, you can log off, you can go back and forth 100 times. It has a little bit of a pre-test and a post-test. And they're developed around topics that will be helpful to parents and caregivers who are dealing with aggressive behavior. So I developed the social and environmental influences on aggressive behavior. Dr. Steve Calculator, who's at this conference, did the communication behavior. Sarika Peters, who used to be with the Angelman Syndrome Foundation, did cognitive and sensory issues. Logan Wink, who's talking now or next, talked about mental health influences on aggressive behavior. And Ron Tebert and Anna Larson did the module on neurologic and medical influences. So what we're showing you is challenging behavior isn't related to any one thing. It could be a number of different things going on. And you have to be able to work through these possibilities to understand what's going to be helpful. Another thing we wanted to point out in the Health Watch table is that the emotional needs of people with severe intellectual disability and limited communication are often overlooked. People are more than just, someone who reacts to what's going on around them. They have emotional needs. They have needs to have friendships and to be included in society and do things with their family and participate in important events. And quite often those things are overlooked. And I'm sure it can be quite hurtful or hard to take for your sons or daughter. So I think it's important to watch for changes in behavior that occur in relation to stressors that have happened in their life or major life events. So big things that happen in our sons and daughters' lives are people moving away, family members dying, new family members coming on the scene, your friends leave, you change school, school ends, you get different workers. So things are constantly changing, which can be upsetting. If you're attached to someone and they're no longer in your life, it can be very upsetting to the person. But maybe we're not good at picking up on some of those things, or maybe we need to do a better job. So there have been tools developed to identify possible signs of mental health problems in people with severe intellectual disabilities. But some of those signs you can look for include increased irritability and agitation. Our guys generally aren't that irritable, but if they were suddenly to become irritable, that could be a sign there's something not quite right. Or changes in sleep. If they suddenly started sleeping a lot, there's a big change perhaps. Energy level changes, their appetite changes, their mood changes. These are things that you should be on the lookout for that could indicate a possible emotional or mental health problem. And consider referring to a psychologist or psychiatrist. Now, they're probably not easy to find, people who work with the population, but they do exist. Some of the tools that I've come across that are used, at least in the research literature, for looking at behavioral emotional disturbance are the diagnostic assessment for the severely handicapped, the developmental behavior checklist, and the aberrant behavior checklist. And I think there's talk lately of something called the ADAMS, is measuring anxiety. So there's a few measures that are being developed, but it's very difficult to measure some of these things, so that's why there's an absence of different things people can use. A group of people I worked with years ago developed an acronym called BEAMS to try to characterize some of the things you could be on the lookout for that might signal the onset of a mental health or emotional issue. So it's like a flashlight beam. So B stands for behavior, E is for energy, A is for appetite, M is for mood, and S is for sleep. And it sort of breaks it down into those different areas. So you're looking for changes compared to how they normally are in terms of behavior. Are they hitting where they didn't hit before? I can't even read it myself. Are they hiding things away? Are they running away from people? Things are out of the ordinary, out of character for that person, are things you want to be aware of. Energy levels. Are they more energetic? Are they less energetic? Appetite. Are they eating more? Are they eating less? Mood. It's kind of hard to tell for Angelman people sometimes, but if you see your son or daughter starting to cry or show signs of sadness or distress as opposed to being happy all the time, that could signal a change. And sleep, of course. Sleeping a lot, sleeping very little, and so on. So those are just a very simple mnemonic that can remind you about some key things to be looking for. What we're also concerned is the duration of symptoms. If it happens once in a while for a few hours, it's generally not a big deal. But if it happens a lot for long periods of time and it happens very intensively and really affects that person's quality of life, that's something to be concerned about.
Just to make a comment on mood, Angelman kids use to smile all the time. When mine doesn't smile, I know within 12 hours she's going to start running a fever.
Really?
So that's the symptom of getting ready to get sick.
So you can see a change in her facial expression going from smiling to not smiling, and you've associated that pretty reliably with getting sick in the next 12 hours. That's really good insight, and that's information obviously you're going to want to make known to teachers and educators and caregivers. Yeah.
Yeah, and we do make that to the teachers where she goes to school. She's 19.
Yeah.
And say if she's not smiling that day, you can let us know because we know within less than 12 hours she's going to start running a fever.
And does she have fevers caused by different things, or is it the same sort of illness?
Stuff like we have. We catch something.
Colds and things?
We fly, we catch something on the plane.
Yeah.
Days later, it hits you.
But that's just the first sign that something's brewing. Any other observations about changes in some of these, the way they smile or how they look or how they sound or move around? If not, it's just something to be on the lookout for. So I wanted to go through a case example that might bring together all these different elements to see how we can use the Health Watch tables and the behavioral modules to try to solve an issue of this young gentleman, Daniel, who's having some trouble. Daniel's a 30-year-old gentleman who lives in a group home with 5 other adults with developmental disabilities. He lived at home until 6 months ago when he required urgent placement in a group home due to his elderly parents' declining health. He takes 3 different anticonvulsants for seizure control. He has a history of choking and coughing at mealtimes and suffers from recurrent pneumonia. Sometimes he will go several days without having a bowel movement. He's able to walk short distances with staff assistance, but is very unsteady on his feet and has fallen a couple of times. The staff don't know, unfortunately, a great deal about how Daniel communicates, apart from reaching towards desired items, primarily other clients' food, or pushing aside things that he doesn't want, such as his own food. They are expressing concern because Daniel has started to hit them at different times during the day, often without a clear reason why. He has also lost interest in some of the activities he used to enjoy, such as watching videos and listening to music. Sometimes Daniel starts to cry and make distressed vocalizations. Daniel's team found that he's more likely to engage in physical aggression or display signs of sadness when he's given pureed foods to eat, a short time after meals, or when straining to have a bowel movement, when his parents leave following a visit, and when he's asked to walk for any distance. After the behavior occurs, he's often spoken to or comforted by staff, he is given assistance, or is able to avoid something unpleasant. So what could Daniel be trying to say through his behavior? He seems to be saying he misses his family. He lived with them all his life, and now he's had to move to this group home. He wants something or he doesn't want something. He wants to be pushed in the wheelchair, he doesn't want to walk, or he feels pain and discomfort. So his behavior is a very powerful form of communication that's telling people around him what's going on. So the staff were smart. They went to the behavior modules and they signed up and got an account, and they read through the modules to figure out what they can do to get more information about Daniel. The first thing they set up was a behavioral tracking sheet, because they decided they wanted to really understand his aggressive behavior and his episodes of sadness. And they realized with all this different staff coming onto different shifts in a group home, you've got to be consistent across the board. So they came up with the definition of the behavior as being physical aggression is hitting staff anywhere on their body with an open hand, and sadness is defined as crying with tears accompanied by wailing sounds. So now everyone knows what to look for. And they track the frequency of the behavior over time. So every time he hit someone, they put a check mark on the chart, or every time they saw the sadness accompanied by wailing sounds, the crying and wailing, they checked that off as well. And they tallied it over time, so they could do it by day or by week. And they found that pretty much it occurred daily, but interestingly, there's a couple of days where there are no behaviors occurring. So again, it gives them a sense of how big a problem is this versus how small a problem is it. They also completed an ABC chart for Daniel, and ABC stands for antecedent behavior consequence. So an antecedent is something that precedes a behavior and a consequence follows it. Gives you a chance to figure out what's going on before and what's going on after. So for instance, setting events sort of set the stage for behavior to occur. So the first row, Daniel was sitting at the table waiting for his lunch. That's what's generally happening in the environment. The immediate antecedent was clients were getting their lunch to eat. So the staff were bringing the lunch over to the table. Daniel hit his staff on the arm. He was told to stop hitting and eat his lunch, and staff think that Daniel does it because he doesn't like his pureed food. So what you're doing is looking at what's going on in the environment generally, what did immediately precede the behavior, what did the behavior look like, and what did we do afterwards. And that starts to give you a better sense of what are the conditions promoting this and what are the conditions maintaining hitting. So then they went through a chart and they tried to identify some of those medical, physical, or emotional factors that could be linked to the hitting and sadness. So they thought that illness was related to it. When he was ill, he was sad or unhappy and hit people. Pain or discomfort, when he was constipated particularly. Not related to seizures, but was related to hunger, or not to thirst or fatigue, not to a change in medication, but a change in diet. Doesn't seem to be related to his mood, an angry mood, but was related to a sad mood, and so on. So So I was trying to get a better sense of, okay, when is this happening? And then they formed a team to work around Daniel. They know that no one person has the answers to all these questions, and in working together, that's where you get your best results. So they brought together a team to work together to figure this out. So they worked with a behavior therapist who worked with them to collect data and analyze the data about his patterns of behavior. The speech-language pathologist assessed Daniel's functional communication skills. The dietitian tried to find out if there's ways to make his pureed diet more appealing, because he thought it was just like dog food. He didn't like it. The primary care physician was looking for possible pain-related issues such as constipation. The mental health professional, such as a psychiatrist or psychologist, was concerned about possible depression following a major life event, which is moving from a group home and leaving his family behind. And the physiotherapist looked into mobility limitations because he only liked to walk short distances. So the team came together, and they're going to work together to try to figure this all out to come up with a plan to help Daniel. But some of the treatment principles we think are important for you all to know about, I'm going to have a hard time reading this, things like treating underlying physical and medical conditions that contribute to behavior and mental health problems. It's really important to find out what the underlying issues are and provide appropriate treatment for them. I can probably read better over here. So treating psychiatric disorders using medication and non-medication approaches according to evidence-based practice for a specific disorder. In some cases, there's no real evidence base of trying something. If you try it for a reasonable period of time, you try it in the safest manner possible, and you collect this information to see if it makes it better or make it worse. In the field of autism, a lot of antipsychotic medications are used, so that's a real concern. I'm not sure if this Angelman syndrome, but you want to use medications that have the lowest profile of side effects. You also want to develop strategies to promote mental wellness, so it's not just medications, but how can you help this person happier and healthier. You want to look at the environment to see if you need to provide more support to the person, and change the environment that's causing this person to become distressed, turn down the lights, make it less noisy, take them to less crowded places, give them more opportunities to do things that they enjoy doing, let them be around people that they like and have fun times with. Offer them choices in life. Don't offer them things. You don't decide for them. Let them decide what they want to do. And try to put them in things that other people participate in, so they can have that chance for relationships and meaningful participation. That gives people more of a life and really attends to their emotional needs. We developed this detective to sort of show the steps that we like to follow in working through some of these complicated issues. We like to start in the bottom left-hand corner where the stethoscope is located, and when there's behavioral issues to sort out, we first want to look for underlying medical or physical conditions, and we want to rule them out first. If we're unsuccessful, or if that only takes care of part of the issue, we want to move on to the environment and support needs. So all of us need support in our environment, and we want to make sure that the support needs match what people need in the way of assistance and so on, and that the environment is conducive to helping them to be as independent as possible and as safe as possible. Sorry, I just lost my screen again. Sorry, it's just taking us a second to pull that back to the detective. Gotta minimize it. Okay, thanks. Then we want to look at life experiences and emotional needs. So we're all affected by what happens around us. People come and go in our lives, things change. We're exposed to trauma, we're exposed to teasing, bullying. Negative things can happen, they affect us emotionally. We have to look for these things, acknowledge them, try to prevent them from happening, but try to support the person if they do happen. And if we've gone through all those steps and the problem still exists, that's maybe a time to consider medication and seeing a psychiatrist. So we don't automatically leap to medication. We look at all those other things that we can do something about, and then we also think that sometimes medication can be very helpful, but we want to do it in a very systematic and coordinated way. The last thing I just want to show you was an article that was written by Anna Larson and her colleagues that talk about issues that affect adults with Angelman syndrome. And a lot of the things we covered in the Health Watch table and elsewhere are really listed at the bottom of the page, things to pay attention to in working with adults with Angelman. Things like seizures, reflux, mobility problems, headaches, communication issues, sleep. All the things that we've talked about as being important are essentially endorsed in the paper that she wrote. So it's a lifelong commitment to try to make sure that people are as happy and healthy as possible. And we're hoping the Health Watch tables can provide some guidance around those important areas to be concerned about. We want to thank the Canadian Angelman Syndrome Society for making our Ottawa clinic possible. Obviously to the American Angelman Syndrome Foundation in the U.S. for all the support they've given us over the years, and the parents and families from the Ottawa clinic who have come to us and been able to share information with us that we think is very valuable. And at this point, we wanted to know, we've covered a lot of ground between this morning and this afternoon. Are we missing anything from your point of view that are important issues that should be noted on a Health Watch table that are important for doctors to be aware about, or clinicians or therapists, or just anyone in general around your sons and daughters with Angelman syndrome?
Well, headbanging and
Head hitting, yes. Self-injury was mentioned a little bit, but maybe not a lot. Would you like to see more information available about that, or that it's emphasized a bit more?
is that the common thing?
Pardon?
Is that common?
It's not as common as aggression. Aggression tends to be more common, but there are cases where children will hit their heads when they're upset. They'll bite themselves, they'll scratch themselves. It does happen, yes. It's not as common, it might get overlooked a bit.
Yeah, ours primarily will bang his head on the wall,
Okay,
frustrated or angry, or he'll take his iPad, you know, and
okay.
do his thing.
Hitting himself with an object.
Broken a couple iPads.
Yeah. How do you deal with that? Well, you try to, first of all, make sure the person's safe, so they're not seriously going to hurt themselves. Sometimes people put padding between their head and the wall. Try to remove the iPad safely and just say, okay, let's just calm down and figure this out. Then you try to follow the steps that I outlined. You try to get a sense of, okay, what just happened before? Was I asking him to do something? Did he not want to do something? Was he looking for something? Something probably set that off and triggered it, I think. I'm going to start to take more systematic information so I can see a pattern emerge. And maybe I can figure that out and think of a different way to handle that situation that doesn't result in him becoming so angry or frustrated that he needs to do that.
You know, what I've found is if you do a preview of what's gonna happen, like we're gonna be addressing when we go to school or whatever, you can let them know up front,
Yeah,
and they tend to know what's going to happen,
okay.
and it helps their behavior.
So sometimes it's the fear of the unknown that having a routine and just knowing what to anticipate can sort of alleviate anxiety or give them a sense of, okay, I'm comfortable, I know what's going to be happening. Yep, yep. Back in the,
My son is receiving ABA services currently. And the interesting enough, though, my question I want to know, because I know you mentioned, ABA is good for, good for kids with Angelman and stuff like that. But the BCBA is stumped by how can I address this behavior, and she's looking for research and she's looking for help. Is there anywhere I can guide her to know? Because I mean, it's different to do like the child with autism than now that she's dealing with a child with Angelman.
Yeah.
She's like, we're not making progress. What are we doing? How do I approach it? We're doing all of this. So, is there anywhere that you can go or any guidance that you could? I know you're saying that your ABA would be good for children with Angelman. Anybody will benefit from it. But when you have a BCBA actually working with your child and they're going, I've tried this, I've tried this, I've tried this. I don't know what else to do.
are they concerned about challenging behavior or they're not progressing? Okay. Well, tell them to go to the behavior modules, the online behavior modules, because there's guidance in the modules about what to do. That's specific for Angelman syndrome, based upon principles of applied behavior analysis, so that should be helpful. I've written a chapter I'd be happy to send along to you that talks about ABA and Angelman syndrome. And I think you can contact ASF, and they have people who will provide advice, family advisors, and different people you can speak to who can try to help as well. So it's the online modules. If you give me your information, I'll send you the chapter, and to call the ASF. I'm happy to send information to anyone, too. Anything else we're missing? So you mentioned the point about we call it SIB, or self-injurious behavior. It might take different forms. And has it ever gotten to the point where he's hurt themselves, like serious injury? Which is good. Like in autism, you can get some very serious injury, calluses, biting through hands, and it's distressing to look at, it's upsetting, and it's upsetting to the person, but it's not causing physical harm. But it's a communication that something's bothering me, something's upsetting me, I'm mad, I don't know what to tell you to do, and we need to help them to find a better way to communicate and a better way to explain things so they don't have to get upset. Maybe knowing, okay, right at this minute you can't have it, but when you're done your TV show, that's where you're going to have it. Sometimes it's just not knowing it's going to happen anyways, but you just need to understand the sequence of events. So it's finding the best way to provide information that's going to be helpful and giving them a way to explain to you in their way, okay, I got it, or I'm still confused, or I still need more help from you. A lot of it's communication, as usual. Yeah. Yes?
Could some self-injury things be more sensory? Because my daughter, she likes to pick her nails.
Yeah.
Sometimes she's like almost pick off her nail, but it's this picking action. I know it hurts.
Yeah. I think sometimes it is. Sometimes kids will rub their skin over and over again. Like we all have habits. We play with our hair. We do pick at our nails. People bite their nails, pick at them. Has she picked them almost off? Is that what you said?
Yeah.
Like right down to the...
Down to the, well, not the whole nail hasn't fallen off. I had to pick it different ways to try to get it up. Like pick stickers. I got a rubber ball and masking tape and stickers over. She was picking that.
Does she do it when she's bored?
I think so.
So it's almost like a habit. Does anyone else have trouble with their son's nail picking? What do you do for it?
I think it's kind of what you're saying, it's kind of a sensory thing, and it seems that she enjoys that feeling of picking.
Right.
Not like the nail, but the part, where your nails come off, like you have like a little part of it, and picking that and picking it.
Yeah.
And it seems to be a sensory thing, so giving something.
It doesn't hurt and it feels good, in a way.
Yeah, and like the paint tolerance, like that is not associated, they just like that action.
Is it possible to replace that sensation with something different that's kind of similar, but that's not actually... Oh, so she'd peel the sticker off the ball? Yeah. Does that work? So you're distracting her by doing something else that she enjoys, and that gets her away from picking at her fingers. Sometimes distraction is sort of like figuring out, well, if I gave you something else to do that you would like equally well, you'd maybe give up on picking your fingers. Yeah.
I'd like to ask everybody, this is specific to my son, who's 13. For no reason, he receives ABA too, but what we have noticed in the last year is he wants to touch hand, wants to hold hand, but as he holds on, he really nails stitches with hand. There's no ask of him, it's not escape. I mean, people are sitting next to him, he gives the attention when he's asking for it. So we could not place it in any type of receipt, we could not put it anywhere. So I'm just wondering, we could not find a pattern to it. It's like just sitting, walking, just doing nothing. He's just seeking for it, and then once he has the hand, he just stays waiting.
It could be sensory too.
Yeah. Yeah.
Can you replace that with something else he could switch into?
Yeah.
Like, can you have like something he could dig his nails into, getting that same input? Could that always be available?
Yeah. He's probably seeking out something. That's the way he's getting it, by squeezing and pushing down. So
Like the nail thing, like
look for a substitute that's not harmful, that you could just maybe shift over, that gives the same sensation. And yeah.
It's common because I can tell I've experienced that almost every single grade. There will be one or two children that they won't be anxious, they'll be very affectionate, and with the very hard, a little bit of that. So it's probably a sensory.
So there's on Amazon, there's school specialty. It used to be habilitations was a catalog, but OTs, PTs, and speech would use a lot. And they have little balls that have the smaller balls inside of it, like with a silicone type thing that the kids
Oh, yeah, yeah.
squish, and
Yeah.
it gives
Yeah.
a lot of resistance,
Yes.
like very firm resistance to them, and they have like little keychain hooks on them that you can give your angel to get that need for deep pressure med that could help extinguish the digging behavior on a person.
Yeah, you're just redirecting them to something that's less of a problem. Sensory assessments might help with some of these things to identify these particular needs that children have to seek out particular types of sensation. And yes, using some ingenuity, talking to people, trying different things to see what works, but if you can shift them or displace it to something else and everyone's happy, that's great. Great outcome. I think we're done then. Any other? Oh, Eric has some questions, I think.
I brought this, one of the parents from the last session that she said, oh, you didn't mention cannabinoids, like all the therapies and we didn't talk about cannabinoids. So our experience is very limited to anecdotes. So we just have families that have come to us and said, oh, by the way, we found it works different in different parts of the world, obviously. So in Canada, we have access to cannabinoid clinics, and then the cannabinoids are the oil itself is paid by the family, so that limits a little bit because it's expensive. But there's a lot of access, and I recall from one family in particular, there was older teenager that was not having seizures at all. The purpose was more to help with anxiety, a bit of agitation, and especially sleep. So I was wondering if there's any experience in the audience, if anybody has used or thinking of or has heard about. Yep. Yeah, that's interesting because, for example, in my experience, I have more experience with a population of children that have a very different diagnosis called Dravet syndrome, that is a form of very severe epilepsy. So it's interesting what you mentioned because many of these families, when they come back, some found that the oil would help somewhat for the seizures, but some also mentioned that there was a bit more alertness or a little bit more kind of like a little bit more steady mood, and maybe and this particular patient that does have Angelman syndrome, she seemed to like it for sleep purposes. But again, I'm just asking, not that I'm neither advocating or criticizing, because I don't have enough experience or a lot of research out there for specifically children or adults with Angelman syndrome, but was wondering if, yeah.
I asked yesterday at the grandparents meeting because our granddaughter's having some aggressive moods, and one person was using it and said it made a big difference with aggressive behavior. It was much improved.
And do you know by chance if it was like an oil, like a CBD oil? The oil? Yeah. Okay. Well, so the marijuana plant has like more than 100 compounds. There's two that are the main active ones. One is the THC, that is the one that gives like the psychedelic kind of behavior, and the CBD is the one that is supposed to help with seizure control. So there are some forms of the plant that were raised to have like very high levels of CBD compared to THC, like 20 to 1 or so. So the oil is essentially there's usually growers or companies that will take that specific variety of the plant, process and deliver this product that is much higher in CBD than THC. Yeah. No, you drink it. So well, a drink sounds like a lot. It really drops. So the dosing is drops. Yes.
Some of my patients are using it for pain control.
Uh-huh.
And New Mexico is a medical marijuana state. So, for example, Colorado's a recreational marijuana state. And just as an FYI, the DEA technically considers that if you're a medical marijuana state, they're okay with that. They won't bother you, although it's still a federal violation, since it's really a Schedule I drug. But that if you're a recreational marijuana state, they have less respect for that, so to say. And also they've told us as physicians that if we are prescribing controlled substances, that technically the DEA considers if you're a medical marijuana state, you can do benzodiazepines and narcotics or medical marijuana, but you can't do both.
Mm-hmm.
That's not to say necessarily they're going to hassle anybody over it.
Right.
We have I have a patient who is on Vicodin 3 times a day, and he didn't like how it made him feel, and his wife didn't like his behavior. And his work comp carrier paid for CBD oil, which he took 7 drops 3 times a day for a week, and then 7 drops twice a day, and stopped the Vicodin completely, and felt much better, and had better control of his pain, and less effect on his behavior and mood. For, anecdotal, but for whatever it's worth.
Thank you. Yeah, that's very.
And supposedly it doesn't, if I understand this correctly, it doesn't show up as positive on a drug screen. It won't show up for THC.
Right. Yeah, there's even a synthetic form of pure CBD that is compounded that doesn't have THC. But, okay. Thank you. Thank you very much. Thank you.